right before we start this presentation, will be given by Dr. Francello, who is fluent in English. I would like just to introduce Dr. Costantino, who is the main author of this research. My name is Marco Colangelo, I'm his assistant. And Dr. Costantino has just a very, very quick, very brief speech in Italian, as he does not speak English, for you all, and I will translate very quickly now. So thank you for your patience. Just for a second.
E io mi occupo dell'impiego della vitamina B1 negli stati di malattia fin dal giugno 2010. Grazie alla collaborazione del dottor Colangeli, che è agronomo, e della signora Maria Pala, che è una coordinatrice infermieristica, sono riuscito a portare avanti i miei studi.
Dr. Costantini would like to point out that he is a neurologist coming from a tiny little research center, a clinic actually in Viterbo, Italy. So we come from the province and we've never been exposed to the full labeled studies that we're presenting today. So we're very grateful to be here, but we started studying the effects of famine in neurodegenerative diseases since June 2010. Thanks to the help of all the collaborators in the little clinic, myself and the head of nurses, Maria Pala.
Noi non abbiamo avuto nessun fondo e per tale motivo i lavori sono essenziali, ridotti all'osso. In questi anni abbiamo avuto un solo sostegno: gli studi fatti da grandi colleghi, alcuni dei quali sono presenti in quest'aula.
This is also the reason why we did not have any sort of financial support during the studies, and therefore you will see that the result of the studies is very essential. It will be just the first very simple facts, because we could not go into a full research on this. The only form of support was indirect that we received. It was through the publication of the works of most of the colleagues, that some of whom are also present here today. And we would like to thank you for giving us the chance to learn more of the effects of famine in many diseases.
Poi, nel settembre 2013, il collega dottor Francello si è interessato al nostro lavoro e grazie alla sua collaborazione che oggi siamo in grado di presentare questi due lavori. Volevo ringraziare inoltre tutti i colleghi, il professor Bettendorf e il comitato scientifico di averci fatto il grande onore di parlare oggi in quest'aula prestigiosa. Grazie a tutti.
Yes, as a final remarks, we would like to thank the colleague, Dr. Francello, who's joined our team of research as of September 2013, and thanks to him we are in a position today to present to you. So we would like to extend our thanks to the participants, ladies and gentlemen, the scientific committee here for inviting us to present this. Thank you very much.
Good morning, everybody. My talks will be focused on Parkinson's disease and the use of ethyme in Parkinson's disease in cerebral attacks. Parkinson's disease is a progressive degenerative disorder of the central nervous system. It's the second most prevalent neurodegenerative diseases after Alzheimer's disease. Clinical features are characterized by both motor and non-motor symptoms. Neuropathological features are the degeneration of pigmented dopaminergic neurons in substantia nigra and of other cerebral circuits. Parkinson is the only chronic neurodegenerative disease with effective symptomatic therapies. In particular, the gold standard therapy is levodopa, but disease-modified treatments are not yet available. Cardinal signs for the diagnosis of Parkinson's disease are bradykinesia, slowness of movements, rest tremor, rigidity, and postural instability. that are described in the UK Parkinson's Disease Society Brain Bank, and also in the American guidelines that include asymmetric onset of symptoms. Here we can see the deep position of basal ganglia in the brain with substantia nigra here, and here there are the complex circuitry. There are two pathways originating from cortex, the direct pathway cortex striatum, globus pallidus internus, thalamus, and back to the cortex, and also an indirect pathway from cortex to striatum, globus pallidus externus, subthalamic nucleus, globus pallidus internus, thalamus, and cortex. Here there is a substantia nigra, which is interconnected with striatum and also subthalamic nucleus. Degeneration of substantia nigra causes a reorganization of the circuitry with overactivity of subthalamus, and then a reduction of feedback to the cortex. Neuropathological markers of Parkinson's disease are the Lewy bodies, intraneuronal perinuclear round eosinophilic inclusion of different proteins, mainly alpha-synuclein. The role played by thiamine in Parkinson's disease have been investigated since the last 90s, and in this work in particular, the authors found that cerebrospinal fluid levels of thiamine are reduced in 24 PD patients, and there is a difference between the patients in therapy with levodopa versus the patient not treated with levodopa. There is also other experimental data. Intrastriatal thiamine induces dopamine release in rat striatum. In substantia nigra pars compacta of Parkinsonian patient, activity of ketoglutarate dehydrogenase complex is reduced. The association between some polymorphism of this enzyme E2 subunit and Parkinson's disease has been found, and the administration of thiamine and acetazolamide improves tardive dyskinesia and extrapyramidal symptoms in psychiatric patients. This is the first report of clinical direct application administration of thiamine in Parkinson's disease, and the authors treated 5 Parkinsonian patients already treated with levodopa with 1, 2, or 200 milligrams daily of thiamine intramuscular, and they found an improvement after 14 days, and 3 out of 5 patients withdrew levodopa. There are 2 main limitations in this study. One is the absence of clinical scale to measure the improvement, and the second one is the short time of follow-up. The experience of Dr. Costantini in the use in the administration of thiamine begins with the treatment of fatigue in inflammatory bowel disease, and then through fibromyalgia, multiple sclerosis, and Dr. Costantini treated also for fatigue symptomatology 2 patients affected by spinocerebellar ataxia type 2, and they improved both in fatigue and in disorder of movement disorder, and so the thiamine was extended. The use of thiamine was extended to ataxia and Parkinsonism, because spinocerebellar ataxia type 2 is an autosomal dominant spinocerebellar ataxia caused by mutation in the gene encoding ataxin-2, characterized by a CAG triplet expansion, and the clinical phenotypes can be or classical spinocerebellar ataxia associated with polyneuropathy or Parkinsonism. And so Dr. Costantini and his group administered three Parkinsonian patients without anti-Parkinsonian therapy, not treated with neither levodopa nor dopamine agonist. And the patient was assessed by UPDRS, Unified Parkinson's Disease Rating Scale, a fatigue severity scale to measure motor functions and fatigue. The patient was were treated for 2 weeks with 100 milligrams intramuscular of thiamine twice a week, and they improved in UPDRS motor part from 31 to 77%. We extended the study to 33 patients with Parkinson's disease, 4 were drug-naive patients, and 29 patients were in treatment with dopaminergic drugs. The patients were assessed with UPDRS fatigue severity scale, and we administered these drugs, thiamine 100 milligrams, vitamin B complex 1 tablet per os, and folic acid twice a week without any change to personal therapy. Parenteral administration is better than oral administration because in Parkinson's disease, gastric emptying has been reported delayed. Uptake across the enteroside was demonstrated reduced or decreased in PD patients. Gastrointestinal dysfunction is common in Parkinson's disease. In elderly people, the intestinal absorption and the intramuscular administration can be altered versus the younger people. And from June 2012, we enrolled 33 patients with mean age of 73 years and mean age of onset of 65 years. And this patient showed an improvement in UPDRS motor part, in UPDRS disease stage, UPDRS functional part, and fatigue severity scale for the 6 patients who complains fatigue. These are the UPDRS score for each patient. The patient were treated continuously. So the first patients were in treatment for 2 years, from June 2012. Okay. This man is 58-year-old. Here you can see the slowness of movement, the absence of pendular movement of the arms during walking, difficulty in turning during walking, hypomimic face, reduced blinking of eyes, and this before treatment. And here after only 2 weeks of treatment, we can see a more expressive face. He blinks his eyes correctly. The speech is more fluent. He smiles.
Comunque poi vediamo, le faccio vedere io un po' non la cosa, come sta adesso. Allora ci alziamo e ci facciamo a solito.
And walking is normal. Depende dal movimento.
Un po' avanti e indietro.
And the agility
Si guarda che la
during walking is normal. and also the face is more expressive. Here, an older patient before treatment. With a stone face, masked face or faccia sfigée, albuminic, bradykinetic with drooling cyclorea in its for a total pulse. One month after the beginning of the therapy, sorry.
Deve togliere la mano.
The signs
Come si sente in generale?
disappear. You can speech.
Si sente più sveglio
Is expressive.
rispetto a prima. Che faceva da giovane?
Here you can appreciate the tremor of right
Quindi i soldi conosce bene.
open mouth, hypogenic
Io
face,
quando resto senza soldi prendo una paralisi infantile e viene. È vero, Carlo?
injury walking,
Te l'avevo mostrate le schede degli asmati, torna indietro verso la foto.
the tremor of right
E poi viene e guarda nella macchina.
tendency to come to
Vieni
corner,
qua, vieni qua.
medium,
Racconti un pochino.
is located
Questo
the face,
che volevo
the
mostrare,
absence of the tremor.
adesso si alza e facciamo una passeggiata fuori. E così apre la porta da sé. Sì, sì. Sì. Ti fa un fischietto.
Adesso
Interesting patient with a tremor left hand, the absence of pedular movement, slowing of walking, the tremor, oral tremor,
adesso si gira cominciare a fare verso la porta.
masked face, hypogenic face, difficulty in turning,
E
6
verso
weeks
la
after,
tranquillo,
there is no
come
tremor at the end.
a posto ferma a guardare lo schermo,
He smiles,
vai verso la porta adesso.
and walking is faster.
Fermati vicino alla porta adesso, girati e fermo adesso, fermo, ti prendo un po'. Fermo, si piega.
Okay. Another one. You can see the different faces and expression of face. And the different type of walking. The last video is the tendency to work with the trunk in captocornea and fixed expression of face.
Guarda un attimo nella macchina, gira, si ferma,
artery and increasing size of letter size. Two patients with cognitive impairment showed an improvement of these cognitive difficulties from 21 to 29 and from 16 to 21. He had no adverse events, only transient paresthesia. Parenteral thiamine, we can conclude that parenteral thiamine is effective in improving motor and non-motor symptomatology in Parkinsonic patient. This clinical improvement is stable over time in all the patients. The first patient in treatment for 2 years. The patient with motor milder phenotype, the 4 patients with motor milder phenotype, had complete clinical recovery without necessity of dopaminergic therapy. The improvement is also in non-motor symptoms, cognitive function, fatigue, and cellular rate fluid. The question is there any relationship between thiamine and Parkinson's disease? 2 recent reviews showed a list of candidate elements to link thiamine and Parkinson's disease from DJ1, excitatory amino acid transporters, ketoglutarate dehydrogenase, coenzyme Q10, P53, and a lot of other potential substances from COX-2 to caspases, BCL2, MAP kinase, and so on. Another work describes an interaction between thiamine and alpha-synuclein. Thiamine lowers alpha-synuclein expression and aggregation in a dose-dependent manner. If you see here, in absence of thiamine, there is an aggregation of alpha-synuclein, and increasing the concentration of thiamine, there is a reduction of aggregation of alpha-synuclein. And the question could be, do we have to increase pharmacologically, for example, the concentration of thiamine to reduce the aggregation of alpha-synuclein in Lewy bodies, for example? We know that in thiamine deficiency, the reduction of alpha-ketoglutarate dehydrogenase activity is regional and time dependent. And we also know that the alteration in functional structural alteration in the brain in thiamine deficiency is related, principally is quite similar to neurodegenerative disease, and the crucial point is mitochondrial dysfunction that leads to impaired brain energy metabolism and failure to cellular energetic production, to inflammation, oxidative stress, excitotoxicity, and cell death. This review is focused on the thiamine-dependent processes in Alzheimer's disease, that is the most prevalent neurodegenerative disease. In the perspective of treatment strategies in neurodegeneration, the authors conclude that thiamine can act as a free radical scavenger. We can hypothesize that supplementation with high doses of thiamine improves the energetic metabolism of surviving cell in substantia nigra, leading to increased synthesis of the endogenous dopamine and to better utilization of the exogenous levodopa. A focal severe thiamine deficiency due to dysfunction of thiamine metabolism could cause selective neuronal damage in the cerebral areas involved in PD. And thiamine can act as both as a rescue restoration with both rescue restoration action and neuroprotective action. The primary cause of PD may be genetic, can cause in a severe focal dysfunction of thiamine-dependent processes, for example in substantia nigra, and in these regions a severe mitochondrial dysfunction that causes cell death, neurodegeneration, and the motor and non-motor symptoms of PD. But at the same time, the primary cause and can lead to a mild dysfunction, a mild diffuse dysfunction in different cerebral areas, and there is no cell death but cell suffering and the appearance of fatigue symptoms. Thiamine might act at these two levels. The conclusion are the necessity for further studies and to investigate the role of thiamine in basal ganglia, in particular whether the dysfunction of thiamine-dependent processes might be a primary pathogenetic pathway in PD, and the necessity for a randomized, double-blind, placebo-controlled study to confirm our data. I want to thank. This is the first patient we saw, the first video.